Welcome back, everyone. I am absolutely thrilled to have you here for part 8 of our Masterclass Explainer series. Today, we're turning this into an active clinical audit session. We are going to navigate some of the absolute trickiest ICD-10-CM sequencing rules for myocardial infarctions. If you're a medical coder, a CDI specialist, or a revenue cycle pro, you already know that heart attack coding is heavily scrutinized. So get ready, because we're locking down the guidelines that will bulletproof your charts against any external audit.
But before we get lost in the alphanumeric soup, let's ground ourselves in the clinical reality of what we're actually looking at. Irreversible myocardial cell death or necrosis due to prolonged ischemia isn't just a paperwork exercise. This represents a critical, life-threatening event for a real patient. ARC coding has to precisely reflect that acuity, the exact location of the damage, and the timeline of the patient's healing process. When we get this right, it ensures the facility is appropriately reimbursed for the intense level of care required, and it paints a true clinical picture of the patient's severity of illness.
For today's session, we're tackling 3 major coding scenarios. We'll look at interfacility transfers, acute MIs caused by underlying CAD, and the rules around acute MIs and chronic total occlusion.
Let's jump right into Section 1, Interfacility Transfers, and how we follow that patient journey.
Okay, let's test your coder instincts with a very realistic chart scenario. Picture this. A patient is admitted to community hospital with severe chest pain, identified as an acute anterolateral wall STEMI. 2 days later, they're transferred to University Hospital for a critical angioplasty. After 3 days there, they are transferred right back to Community Hospital to continue their recovery for another 4 days. Real-world charts get messy like this all the time. So how are we coding the principal diagnosis for each of these 3 distinct admissions? Think about it for a second. Well, the official guidance here is actually brilliantly simple. Across this entire timeline, the principal diagnosis code remains exactly the same for all 3 encounters, I21.09. Now, you might be wondering, why doesn't it change when they go back for recovery? Because across this entire patient journey, the myocardial infarction is still actively being treated. It hasn't resolved yet. Even during that final return for observation, that acute MI is still the overarching reason for the care being provided. So just to cement this rule in your mind, an unresolved, actively treated MI retains its acute category code throughout the entire transfer chain. You assign I21.09 as the principal diagnosis at Hospital A, over at Hospital B, and upon return to Hospital A. Any underlying coronary artery disease they might have, that is simply reported as a secondary diagnosis.
Moving right along to Section 2, let's look at acute MIs due to underlying CAD and nail down that principal diagnosis selection.
Here's your next chart challenge. A patient presents to the ED with an acute myocardial infarction, but the provider documents that this MI was specifically caused by underlying coronary artery disease. The patient then undergoes a cardiac intervention. Mentally lock in your principal and secondary diagnoses right now. Between the MI and the CAD, which condition gets top billing?
The acute MI wins the top spot every time. The principal diagnosis must be the acute MI, and the coronary artery disease is sequenced as the secondary diagnosis. Honestly, this is an area where consulting physicians often have misconceptions. They sometimes assume the underlying chronic root cause should be primary. But in the coding world, the acute, life-threatening event that actually occasioned the admission always takes precedence.
So why do external auditors absolutely love the flag charts where CAD is mistakenly sequenced before an acute MI? It really comes down to a fundamental misunderstanding of the rules by clinical staff, who naturally tend to focus on the long-term disease process rather than the acute presentation.
The rationale here is clear-cut. The acute MI is the immediate, emergent condition that required inpatient care right then and there. While the CAD is absolutely the chronic underlying etiology, UHDS guidelines strictly dictate that the acute condition prompting the admission takes the principal spot. If you sequence CAD first when an acute MI is present, it's almost certainly going to lead to a DRG shift, a failed audit, and a massive headache for your facility's revenue cycle.
All right, on to our third and final section, acute MI and chronic total occlusion, focusing on vessel differentiation.
First, let's briefly define chronic total occlusion, or CTO. This is a complete blockage of a coronary artery that has been present for typically more than 3 months, coded to I25.82.
Now, if you look up this code in the tabular list, you're going to immediately notice a glaring excludes one note linking it to acute myocardial infarction. And as we all know, excludes one notes are basically the speed traps of medical coding. They will catch you if you aren't paying close attention.
Which brings us to this highly specific scenario. What happens when a patient is admitted for an acute MI and the subsequent cardiac cath reveals a chronic total occlusion, but that CTO is located in a completely different coronary artery than the one that caused the acute MI? Can we code both of them despite that excludes one note?
Here is your golden exception rule. When the acute MI and the chronic total occlusion occur in different coronary vessels, they are considered clinically unrelated to one another for that specific encounter. Because they are distinct issues in totally distinct locations, the excludes one note actually does not apply here, and you are totally cleared to report both codes together.
But just to ensure we fully understand the boundary of this exception, let's flip the scenario for a second. What is the coding logic if the provider documents an acute MI and a CTO, and they are both occurring in the exact same vessel?
This is the rule to burn into your memory banks today. If they're in different vessels, green light. You code both the acute MI and the CTO. But if they are in the same vessel, that excludes one note hits the brakes. In that case, the CTO is considered part of the disease process that culminated in that acute infarction. So you do not code the CTO separately. You only code the acute MI.
As we wrap up this active audit session, I want to leave you with this provocative thought. Are your facility's charts accurately capturing these minute nuances? Are you correctly differentiating the sequencing for interfacility transfers, underlying CAD, and those vessel-specific CTOs? Because getting this wrong doesn't just skew your clinical data, it heavily impacts hospital revenue and invites major compliance penalties. Take these rules back to your teams and audit your own charts before the payers do.
Decode Healthcare with Harshal.